Welcome everyone to the Bergman Forum, which is now running for its 52nd year. I like to think of it as the intellectual pulse of Alfred University. It beats slow once a week, but it beats strong, and it shows that minds here are still alive, curious and creative. We had hoped to be once again holding the forums in person this semester, but sadly, given the ongoing situation with respect to the COVID pandemic, we're not able to do that yet. So for the time being, we'll continue to hold the forums online. The Provost's office will send an announcement out every week, along with the Zoom link. The schedule for the entire semester has already been circulated. If you don't have a copy of the schedule and you'd like a copy, just email Marilyn Saxton or me. If you looked at the schedule, you'll know that we have an exciting set of presentations in store from a wide range of fields, including natural science, social science, history, and the arts. And I want to express special thanks here to Gary Ostrow. As usual, I had a full schedule drawn up last May, but then there were a few last-minute cancellations. Gary had some great ideas about how we might take advantage of the fact that the forums would be online. He used his connections and reached out to several scholars with Alfred connections who agreed to present. The result is that we have a decidedly distinguished roster of speakers this semester. So thank you, Gary, for all your help and your silver-tongued persuasive powers. Today, for our first forum of the year, we're delighted to have a joint presentation. Lauren Hall is Professor of Political Science at the Rochester Institute of Technology and the author of The Medicalization of Birth and Death. Bill Coch, who I know is familiar to many of you, has been a practicing physician in the Alfred area for over 40 years and is the attending physician at the Comfort House in Wellsville, which offers end-of-life care. And between them, they will be discussing the politics of healthcare reform and the end-of-life medicine. So take it away, Lauren.
Thank you. Well, thank you all for having me. This is a wonderful forum. My goal right now is to actually spend just a little bit of time talking about the research in my book and some of the findings that I came out with. And then I really want to leave a lot of time for Bill and I to chat, especially because of his background in comfort houses. And then hopefully we can open it up to broader Q&A. So this book was actually a departure for me. I'm a political theorist by training, which means that my background is really theory and philosophy as opposed to policy. But it was also kind of a long time coming. I did have a background in biomedical sort of theory and bioethics. And so when I would say the origin of this story was actually watching both of my grandparents die in hospice over the course of about 10 years. So my grandmother died when I was in graduate school, and then my grandfather died about 10 years later. And they actually had, relatively speaking, very beautiful deaths. They died at home, they died surrounded by family and friends, and it was about as non-traumatic as death can be. And it wasn't until very later, much later, that I realized that that's actually a kind of a unique experience. And we can talk a little bit about why that experience is not as common as we might hope. What really sort of animated the book, though, I mean, those experiences were in the back of my head, but what really sort of animated the book was my own birth experiences. So when I was pregnant with my first daughter 9 years ago, I was looking for a specific type of maternity care. I was a low-risk woman. I had a healthy pregnancy. And what I really wanted was relatively low-risk physiological birth with midwives. And so I looked around for a birth center because that's sort of the standard in many other European countries, and we don't have any. And so New York is actually very odd. When I was looking into giving birth, we had 2 birth centers in the entire state. And now almost 10 years later, we still have 2 births in the entire state. And that to me is very odd. And so I started by just asking questions. And this is what academics do when we don't know anything about what we're researching, is we go and we ask questions. So I went to midwives and I said, why don't we have any birth centers? And I said, well, they're not profitable. Nobody can make a living owning a birth center. And I said, okay. And that seemed like it might make sense at the time, until I realized that lots of other states have birth centers and lots of other states have lots of birth centers. And so it struck me as that there's something else going on here. And so why is it that New York has 2 birth centers for millions and millions of people, but states like Oregon, Washington, Texas, South Carolina have lots and lots of birth centers? So it didn't seem like the profit argument was making much headway for me. So as a political scientist, I did start looking at some of the policy. And when I originally started writing this book, I actually thought that the primary sort of argument was going to be a cultural change, right? A cultural change in what patients expect, a cultural change in sort of how we think about both birth and death. I thought we were going to talk a lot, or I thought I was going to talk a lot about the sociological concept of medicalization, which is the move to place more and more facets of human life under the control and auspices of medical care. And it turned out that that was an important part of the book, but what ended up happening is that the policy chapters ended up eating the book. So I started out with a single policy chapter, and then that chapter got bigger and bigger and bigger and bigger. And then all of a sudden, the cultural piece, the other piece, which I still think are important, and I think sociologists are doing fantastic work, medical anthropologists are doing fantastic work in this area. But for me, at least, as a political scientist, the part that I did not think was getting enough attention was the political piece, right? So what is it that we're doing wrong on the structural level that is eliminating options for people and making it very difficult for people to get access to the kind of care that they want, and in particular, making it really difficult to get access to demedicalized forms of care. So in the book, I talk about birth centers, I talk about home birth, I also talk about hospice, I talk a little bit about comfort homes. This part of New York is very unique because we have a large number of these comfort homes for people at the end of life. And those are essentially unknown in the rest of the United States. And so we've kind of institutionalized birth and we've institutionalized death. And I wanted to try to understand why that was the case. So without giving you a huge, again, I want to leave a lot of room for conversation and also leave enough breadcrumbs. So some of you at least are interested in buying the book at some point. I'll just go through like the major policy pieces that I found as being particularly important in driving this medicalization. And the really crucial ingredient, the really crucial linchpin, what were those policies that prioritize hospitalization and prioritize hospitals over other kinds of care. So I'll zoom you back to the start of the 20th century, and what we had at the time, actually in the late 1800s, early 1900s, was a pretty diverse medical landscape, and not always in a good way. So you had physicians and you had midwives, but you also had quack doctors and you had apothecaries and you had people selling like cocaine and soda bottles and like all sorts of weird, lead in tinctures that people were drinking, and so there was an enormous amount of, and because the United States is a federal system, and because of the way that the Constitution is written, healthcare has always been a function of the states. And so there really wasn't an opportunity to get any kind of uniform federal policy because medicine didn't fall, and healthcare broadly never fell under the auspices of the federal government. It was really a state policy area. And so what happened very quickly is that physicians looked around and they particularly looked at countries like Germany. And this is where Johns Hopkins, for example, is modeled on the German principle of medical care. And the idea was that medicine really needs to be scientific, it needs to be objective, and we need to be able to measure the results. And that's how you're going to get really good outcomes. And it turns out that that kind of research is really, really good for solving acute medical problems. It's really good for developing antibiotics. It's really good for developing organ transplants. It's really good for doing the research that can save people in these kinds of acute crises. That kind of medical care is not as good at solving chronic human problems like diseases or conditions that result from poverty, public health problems that result from, now, for example, we're facing an obesity crisis. And so it turns out that there's a sort of, we captured under or rather we chose a very specific kind of medical model that was very, very good at acute medical care and less good at preventive care. Now, that wouldn't have been a problem if it wasn't also combined with a variety of political movements at the turn of the century, which ended up prioritizing that kind of care. So the first step was licensing. And again, licensing was one way that states tried to minimize the diversity and standardize medical care. And so you got licensing of obviously medical providers, but then also there was this movement to license nurses and place them under the banner of physicians. And then also licensing people like midwives and placing them under the supervision and authority of physicians. So licensing is kind of the first step, and I'll talk a little bit more about that later. And so what ended up happening is that medicine becomes really quickly standardized. It becomes the authority of physicians who are trained and practice in a very specific kind of medical model. And other providers like nurses, like midwives, like nutritionists, like all these other people end up to a certain degree sort of under that medical umbrella. So licensing is the first piece. What happens in the middle of the century is that people are coming home from war, World War II. It's 1946. We need sort of a jobs program for people who are coming home from war. And so the government says, well, let's figure out what we need. What do we need? We need more hospitals. We need community hospitals. There's all these rural areas that don't have any community hospitals. Let's build a bunch of hospitals. And so the Hill-Burton Act of 1946 really dramatically pumped huge amounts of federal dollars into building hospitals. Now, that's not in itself a problem, except for the fact that the structure of the law was problematic for a few reasons. One, it was expansionary. So the understanding was, we'll just keep needing more and more hospitals, right? We'll need lots of hospitals. And so we should keep funding all these hospitals. And then because it was expansionary, you needed to keep staffing those hospitals. And so very quickly, you now had hospitals in every community that were essentially, to a certain degree, too big to fail. Right? They were these huge pieces of expensive infrastructure. It's very hard to close community hospitals, even when they're not actually doing what they need to be doing. And even when resources would actually be better spread out in other kinds of ways. So one of the things that the Hill-Burton Act did is it really prioritized hospital spending and therefore did not prioritize the kind of primary care, preventive care, in-home care that it turns out actually now we really, really need. So the sort of icing on the cake then is the creation of Medicare in 1965. So what Medicare does is it's the first, and the sort of the roots of Medicare are very interesting. I highly recommend the book by Paul Starr, S-T-A-R-R, The Social Transformation of American Medicine. He's a sociologist and he does a beautiful job just sort of laying out the changes to the medical sort of framework in the US. But one of the things that Medicare does is it's created with physicians. So it's very heavily influenced by hospital associations and physician associations. And it's created as a way to provide insurance for the elderly, so people 65 and older. And then Medicaid follows shortly thereafter as a way to provide medical care for the poor and low income folks. And in both cases, though, the goal of the physician organizations was to preserve practitioner independence. They really wanted a lot of physician autonomy. And so the way to do that then was to have as little government control over the actual healthcare that was provided, but instead create what is now called the fee-for-service system. So whatever a doctor does to you, Medicare will pay for it. And that was actually okay in the 60s when you couldn't actually do a lot to people. So you could give them antibiotics, you could do, or like we had limited technology in the 1960s. But then there's this dramatic period of medical growth starting in the 1960s through the 1980s, where all of a sudden you have this huge growth of medical technology. We can keep people alive with ventilators and just a variety of other kinds of, we have the first organ transplants. They start earlier than that, but really the first successful heart transplants, kidney transplants. All of a sudden we're keeping people alive who would never have been alive previously. And it's becoming harder and harder for Medicare to figure out what to do about that. And so you see some early questions about what to do about people who are on dialysis. Dialysis is very expensive. And so various community or various state and federal kinds of policies were trying to figure out how to essentially ration dialysis because it was such a huge cost on Medicare, and we could not figure out how to support the patients who needed to be supported this way. So the creation of all of these new technologies very shortly after Medicare is created meant that the cost of the program just exploded. And so very quickly, what we have is oversupply of hospitals, oversupply of physicians. We have an incentive structure written into Medicare and Medicaid that says you get paid more based on what you do to patients. So the more that you do to patients, the more money you make. And one thing that's crucially not included in Medicare and Medicaid is reimbursement for providers to do basic things like communicate. Right. So if you have a meeting with a patient, a terminally ill patient, to talk about end of life goals, you never get reimbursed for that. That's not covered under Medicaid. That's not covered under Medicare. And so the kinds of really high quality communication, preventive care, primary care that we really actually need is not covered under the current system, but we prioritize lots and lots of unnecessary technologies and other kinds of interventions. And so what we have is a highly interventionist system. It's a highly expensive system, and it has relatively poor outcomes. So there are some areas that the US does better than other countries on. We do very good on areas that need a lot of technology. So if you need a heart transplant, the US is probably one of the best places in the world to get a heart transplant. If you have a really rare type of cancer, the US is going to be a really great place to get care. But if you're dying of some kind of slow terminal illness, if you have dementia, for example, it's going to be very hard to access the kind of care that you need, which might be home health aides. It might be someone to just come and make sure that you're safe at night. You're not going to get the kind of care that you need, at least not covered by government payers and most insurers. So that's kind of the policy landscape. I'll end with a couple quick sort of solutions that I discuss in the book. I was thinking about how to frame this very simplistically earlier today, and I actually came up with an acronym that the acronym is actually DIE. So that's a little bit hopeless. Like, I don't want that as the acronym for the future, but it's essentially deregulate or rethink regulations. And I think Bill and I are going to talk about that when it comes to certificate of need laws in just a second. We need better integration across care providers. So one of the problems is that physicians are really siloed. The rise of specialists means that there's very often nobody driving the bus. I've talked to multiple palliative care physicians who say, you've got an oncologist who tells you one thing, you've got a kidney specialist that tells you something else, you've got a heart specialist that tells you something else. Often they're all prescribing different meds and nobody's actually coordinating care. I know that in my own experience, my grandfather was 90, he was 93 when he passed away. But he was on something like 15 different prescription drugs a couple of years before he died. And my mom actually had to step in, and she had to coordinate with the doctors and the nurses which ones he was going to get off. And she basically said, you can choose 5 drugs that this man can be on, but he can't be on 15. And we know that when people are on 15 different drugs, we know that the elderly are very susceptible to serious drug interactions that really dramatically affect quality of life. And yet, because we don't have integrated care, nobody is able to really control that kind of overtreatment. And then the final piece is really, we need better education. So we need to educate. And so one way of thinking about this is that we have system level failures, which are really the Medicare failures, the Medicaid failures, the Hill-Burton Act, right? Those are kind of system level failures. But then we also have provider level failures, failure to communicate, failure to integrate. And then the third piece is patient level errors. So there's a lot of patient level errors, right? People make mistakes about their goals. They don't understand adequately. They have a really hard time understanding the consequences of certain kinds of treatment decisions. And so I would say that one thing that we really need to move toward is better education about, in particular, end of life care, and start it much earlier. So one thing that came out of a lot of my survey data was that the sort of major education that people get in end of life care is when somebody they love dies. And that's in a lot of ways too late. So I'll end there, and I want to see what Bill would like to chat about, and then also see if the audience has any questions.
Great. That was a really nice presentation. I do want to correct something you said, that Medicare doesn't pay for physician conversations. In fact, 4 years ago, Medicare said, we'll pay you to bring a patient in and talk about end-of-life goals. And then the death panel argument got going, yes, that they were trying to kill people to save money. And so nothing is easy.
Yep, agreed.
But one thing I'd like to ask you is, is you surveyed a lot of providers, and you interviewed a lot of providers and surveyed a lot of patients about end-of-life care. And I'm curious as to what people think about end-of-life care that's available now.
In terms of patients or
Yeah, in terms
providers?
of patients or families. What did you find? You had a good experience with your grandparents, but
Yes, and they had very clear wishes. And we also, another really crucial piece of this, and this is maybe one of the biggest patient level errors, is that we had no family conflict. So everybody knew what my grandparents' wishes were. It was very clear to everybody that they didn't want, my grandfather was 93 when he died. He did not want extraordinary treatment. He did not want any kind of serious, he didn't want to be intubated, right? I mean, so everyone was clear on those goals. And one of the things that does come up in a lot of those surveys is that there is a lot of often conflict. People don't communicate their desires early enough. And so it's hard to know what people actually want when they're at the end of their lives. Two, though, areas that I think people were very frustrated with in the patient survey data was lack of communication or poor communication, confusing communication with providers, particularly when you're dealing with multiple specialists. And then the other one was really traumatic transfers of location. So the movement from a nursing home to a hospital, and then from the hospital to the skilled nursing facility, and then the skilled nursing facility back to the nursing home. And we know that the more transfers you have, the increased risk of medical errors and all these other problems. But that was a really hard thing for a lot of people because people thrive off stability, and certainly transfers are physically traumatic, but also they can be really psychologically traumatic for families and the patients themselves. On the provider side, and I would love to hear your thoughts on this. I mean, I have talked to many palliative care physicians who are just very, very frustrated with what they see in hospitals. And it's easier. I've talked to a few who work in both the hospital and the home environment. And one of them, he said, I can provide much higher quality medicine at home than I can in the hospital. He feels much more restricted by protocols. He feels much more restricted by the presence of specialists who are influencing his care. And so his frustration was really that he doesn't feel like he can practice the kind of medicine that he needs to in the hospital context.
My context has always been a small, Jones Memorial Hospital, which is a small rural hospital without a lot of specialists. And I would say that community hospitals in general do a lot better than medical centers at dying. We have thanks to a family that dedicated the money, a designated end-of-life room, and it doesn't, it's like these rooms on OB now. It looks like somebody's, home. And I think community hospitals do a much better job. There's less people looking over your shoulder so that you can use appropriate doses of narcotics. And I've had it happen even in our hospital, but the amount of sedation and narcotics you often need to use to give somebody a comfortable death are really astronomical sometimes.
Yes.
And sometimes there's a pharmacist or a nurse or somebody who feels really uncomfortable and complains, and then of course then you back off. So I'm sure that's multiplied manyfold in a big hospital.
Yes, I think that's absolutely true, and I think that I do think the community hospitals there's also just a familiarity. The staff know each other more. There's a history, which means that people can trust each other in a variety of ways. That I think is definitely harder in the academic in the large academic hospital.
I'm assuming that the interviews you did were at people at medical centers.
Yes. Yes. So most of them were either strong or actually a couple big hospitals in the Pittsburgh area. But I did interview physicians who worked in comfort care homes, and some physicians who did home hospice work. And again, I would love to hear sort of your perspective, but I find that they were much happier with the work that they were doing in home hospice. So there were fewer concerns about overtreatment, fewer concerns about, for example, opioid dosing, which came up a lot in my conversations with hospice nurses, for example, that hospice nurses felt like they couldn't They were under much greater scrutiny for the kinds of care that really was needed by terminally ill patients in a hospital or the skilled nursing facility context, whereas at home they really have much more ability to treat the pain that patients have.
Well, so speaking of that, I was a hospice medical director for a long time, and the hospice is great, and often it works out just fine, but it's become pretty bureaucratic. So, for example, when somebody needs an increase in narcotic dose at 9:30 at night, that has to go through the doctor, and so it's not very nimble, and often it doesn't get solved until the next day. And I often found, for example, one of the things that people at the end of life often need is physical contact, touch of other people. And volunteers in hospice are pretty much forbidden, and this is even before COVID, from even touching patients. They can't really, they can't help them to the bathroom. A volunteer, and often people are asking hospice, well, what can you send me? And you point out in your book that hospice, they can send in somebody to do personal care like 1 hour a day at most. They don't provide too much help, but often they'll provide volunteers, and the volunteers can sit with them, and that's good, and read and stuff, but they can't touch them. They can't really help them to the bathroom. They can't, there's lots of things they can't do. But along those lines, could you talk about hospice? You pointed out that that hospice has become a major profit center, and it's been pretty much taken over by for-profit companies. Could you talk some about that?
Yes. So one sort of, and there's a lot of double-edged swords in healthcare. And so I don't want to come off as too negative about sort of the structure of Medicare, broadly speaking, but when the Medicare hospice benefit was formulated, it was really aimed primarily at patients that had a very clear timeline for death, right? A physician could look at that person and say, I'm pretty sure this person's going to die within 6 months. And so really, we can provide this kind of care, and it will be cost effective. Now we have lots of people who are getting who really need hospice, who don't qualify because of the 6-month limitation. The Medicare hospice benefit, I believe this is still the case. It doesn't apply to children, but it does apply to adults, that you have to give up curative treatment. So you can't get hospice care if you are still pursuing other options, which means that a lot of people do view hospice as just a place to go to die, right? It's really changed the culture around hospice care. And that's why you get this growth of palliative care as a specialty, which at least one palliative care physician that I talked to said, it's just crazy that we're a specialty. Like every doctor should be trained in the kinds of skills that palliative care physicians are. Like he said, it's actually insane. So that I think is a lot of frustration. But one of the things too that the Medicare hospice benefit did is that it really kept reimbursement very low. It's a low standard rate for each patient. It's a per diem rate. There's some more complex patients you can bill at a slightly higher rate, but really it's a very low rate. Most hospices have enormous amounts of uncompensated care that they have to pull from donations and things like that. And then the other addition, which you and I chatted about a little bit offline via email in some of your questions, is that in many states you have certificate of need laws, which are laws where you essentially have to demonstrate to the state that your services are needed. And the process is very expensive. And so what has happened in a lot of states is that the only hospices that can make it through that process are corporate hospices that have cash reserves. So in Florida, for example, that has a certificate of need process for hospice care, when I was writing the book, there was a couple court challenges to the certificate of need process, but the only corporate or the only hospice to make it through that certificate of need process was a corporate hospice. And they spent something like $1.2 million on the certificate of need process, on the regulatory process. So no small nonprofit hospice is going to be able to get through that hoop. And so the largest sector of growth in hospice is for-profit hospice. And so we see kind of predictable outcomes, right? We see that for-profit hospices have there's some evidence, this is a little bit unclear, but there's some evidence that customer satisfaction or patient satisfaction is lower with for-profit hospices. We have some evidence that fraud might be a little bit higher. We do have evidence that for-profit hospices frequently try to avoid taking complex patients because complex patients have higher amounts of uncompensated care associated with their care. So I think we've made a trade-off, right? And this is true across the healthcare arena, is that a lot of the laws that we have at the state level really encourage corporatization and encourage consolidation. And so one of the really big fears that a lot of healthcare reformers have is that we've encouraged consolidation now to the point where, it used to be that most physicians were independent providers. Now most physicians are employees, and they're employees of large hospital practices. And so whether those hospitals are nonprofit or for-profit isn't the point. We've corporatized it. And that really changes the nature of patient care. It changes the relationship that people have with their patients. It's bureaucratized, the kinds of bureaucracy that you've found in your own care. It makes it harder to provide nimble care that really responds to the needs of people in the moment. So I think we've lost a lot in that move. Hospice used to be small scale providers, heavily staffed by volunteers, usually with a religious bent, often affiliated with churches. And now, again, the largest growth sector is these large for-profit hospices.
I was interested to learn that the comfort home movement, of which I'm a part, is really a local phenomenon. I did not know that. Maybe you could talk a little bit about what you've learned about comfort homes in general.
Yeah, I did not know that either. And it actually wasn't until I was interviewing palliative care physicians who live outside of New York that a couple of them said, "Oh, I've never even heard of that before." And I said, "Oh, really?" And then I interviewed a few of the comfort home directors for the book, and it's actually a very interesting model, which you could obviously speak about too. But part of what makes them often successful is that they really fly under the regulatory radar. So most of them are 2 beds. So that they don't have to meet nursing home regulations or hospital regulations. It's essentially just a house. Right. And then the hospice agencies have their own regulations that they have to abide by. But it really is a kind of almost like a mutual aid approach to terminal and end of life care. And I see it as sort of the demand for it in this area, I think, seems to be spreading in part as a response to the corporatization and the institutionalization of death. Why it has not spread in other areas, I think people just don't know about it. That was actually one of my, it's in the back of my head as a potential next project, just looking at the growth of comfort care homes in this region and why they've done so well here and not necessarily spread elsewhere.
I think you identified one of the main factors why they can be successful is because they're under the radar. As soon as you begin, setting standards and also introducing money into the equation, it starts getting complicated. Somebody has to audit. Did you meet these goals? Are we paying for what we're getting? And all that. And it really requires a huge commitment from the community to support comfort homes. Financial, which actually our local comfort home, we do really well financially, and it's more trouble getting volunteers.
Okay. Yeah.
But I think lack of regulation, although that it could be very abusive, is important for their success.
Bill, could I
Yes.
just intervene something?
Yeah.
That is, just to keep our eye on the time. At the moment, it's 10 to 1. Normally what happens with the Burger Room Forum is we finish at 1. What's going to happen today is there's a lot to discuss and people have questions. So how about if you guys take another 5 minutes with your conversation and then we open it up to other people as well to ask questions?
Well, if there's lots of questions, why don't you open up now? I mean.
Okay.
Yeah.
If Mari, could you allow people to unmute themselves, please?
Yep, all set.
So, Vic, you had a question.
A couple of comments, if I may. First of all, my background, I'm a retired physician. Um, Graduated from medical school in '65, so that gives me a little bit of mileage. My last 10 years were spent in an outpatient clinic devoted to liver transplantation. I've always had an interest in end of life and have been pretty good at it, I think. Some of the issues are cultural, having to do with end of life, and I think they're very difficult to deal with. It has to do with how we're, if you will, brought up professionally. We're brought up, trained to cure, to make things better, to solve problems, and to do so largely in a physical and pharmacologic way. And it's very, very difficult for, I would say, the vast majority of physicians to set other goals. It's much easier to solve a problem by adding more in the way of technology and therapy than it is to sit down and talk with people. And it's extremely difficult for physicians to do that. I mean, I did it, and I did it fairly well, but I was really rather unique in doing that. And it just rubs across the grain. It's very, very difficult for people. I'd like to make another thing that gets in the way there, it has to do with malpractice and defensiveness. I know that there are studies that suggest that malpractice concerns don't add that much to the burdens of what's done. But having worked on the inside, I think it's a big issue. What would the lawyers say?
I totally agree with you on that.
Having to do with this decision or another decision. Another comment, if I may, and it's out of my own field of expertise. My wife is a pediatrician, and we're old enough to know a lot of people who've had babies in a lot of different ways. But going back to your reference to the medicalization of birthing, I would argue that there's a strong case to be made for that. Yes, I know it diminishes the, if you will, touchy-feely and spiritual aspects of the experience. But the stakes are so enormous in terms of maternal well-being versus maternal death and infant well-being versus infant death that I think one has to leave a lot of room for, if you will, the medicalization. If you have a home delivery, however it's attended, and there's a problem, it can be so catastrophic. And the United States does not have the kind of prenatal care and systems that reduce infant and maternal mortality the way they should. So I would make an argument for going slow on, if you will, the spiritual approaches to birth. I think that's enough from an old fart.
Just very quick, I just want to address the birth piece, because I think that it's such a common concern, and it's obviously a really important one. The evidence actually just seems to demonstrate, though, that we overtreat. I mean, the C-section rate for low risk mothers is well over 20%. We overtreat. That leads to catastrophic failures down the line. So when you've had
Absolutely.
a C-section for the first one, it becomes harder. But the overall safety of home birth with trained attendants, so with trained midwives, is actually very, very, it's very, very safe. The question is, are there incentives within the U.S. healthcare system that make it less safe? And I think that the same problems of integration exist at the home birth level that exist at the palliative care level. And so a big argument that I make, I mean, there's a reason that home birth is safer in Denmark and the UK than it is in the United States. And that's because midwives are fully integrated into the system. And so they can call a physician and ask them for assistance or just ideas during a labor, and you frequently can't do that in the United States.
Yeah.
So absolutely, the stakes are very high. And what I'm actually arguing for in the book is not a sort of more spiritual approach to birth. It's the appropriate medicalization of birth. So how can we eliminate the unnecessary treatments and really focus on appropriate care? And the same is true at the end of life. So when I talk about sort of over treatment, I'm very in favor of large doses of opioids at the end of life. People have uncontrollable pain. That's not the kind of treatment. So what I really want to make sure people hear from this talk is I'm not against medical care. What I'm trying to look at from the political perspective is what are the barriers to appropriate medical care?
The corporatization that both of you have mentioned is becoming so overwhelming that first it was medical facilities that bought up other practices, hospitals bought up practices. Now it's investment bankers. And their measurements and their metrics have virtually nothing to do with the, if you will, the spiritual aspects or the more humane aspects of medicine. It's incredible. And again, talking about end of life, when I talked about these things with patients, first of all, you can't do it in 10 minutes. And when you're done, or at least when I was done, I was exhausted. It's very, very strenuous emotionally if you do it right.
Okay, let's open it up for anyone can ask questions. I mean, I'll pose a question. Lauren, I don't know if you talk about this in your book, but generally speaking, I mean, Vic's representation of physicians is fairly as benevolent, but isn't it true? Isn't it bluntly true that there can be a conflict of interest, which is, I mean, in many fields we will do everything to avoid a conflict of interest. But if a very old person if a physician is going to make a lot of money out of a procedure, then why isn't that a glaring conflict of interest which could affect their medical judgment?
Yes, I worked really hard in the book to sort of presume good faith on the part of most physicians, because I was being very critical of the sort of medical system as a whole. But we absolutely know that that physicians are human beings, and they have very similar incentives to every other human being who operates. And so we know, for example, that the most common time to get a C-section is right before lunch, right? It's also right on Friday night, right before shift change. People respond to incentives in a variety of complicated ways. I quote this author in the book, and I'm trying to remember who it was, but there's a wonderful letter from an oncologist who is just brutal about overtreatment in oncology, right? He says, why are we pumping people full of chemotherapy 2 days before they die? It's torture. It's medical torture. We are actually torturing people to death. And a big part of it is the incentives, right? For the vast majority of oncologists, all of their income comes from the chemo drugs themselves. They have to keep an entire office staff employed on that money. And I think it does color the way that we think about, or the way that they think about sort of patients. And then you add that to the comments that Victor made about sort of the culture of medicine, which is you feel like you're giving up if you refer a patient, you say, well, we're on third line chemo now or fourth line chemo now. There really isn't anything more we can do. That feels like both a personal failure, but also a professional failure. So the financial incentives line up with the personal incentives and line up with the professional incentives. And it's very, very hard to figure out what to do in those contexts. My sister's a palliative care nurse practitioner. And so she has struggled for the last, 5 or so years to to try to understand the kinds of incentives that physicians are up against, because she'll see doctors making these decisions that from her perspective are simply insane. They're simply malpractice from her perspective. But from the doctor's perspective, there's all of these other swirling kinds of pressures and interests. And of course, that's true of all humans, but medicine is the stakes are much higher, and very often the time frame is much more limited. You have to make a very quick decision in a very limited amount of time. But we know, of course, that there's lots and lots of examples of doctors behaving in fraudulent ways and abusing patients. And so it's certainly not, the incentive problem is real. And it's made worse by the structure of our reimbursement system.
Well, I was going to say, I mean, some of the things with doctors being human, like the rest of us, are hard to deal with. But the financial incentive it's got an obvious solution. Doctors should be salaried. I mean, if, for instance, I, as a professor, I got more pay depending on how many students got A's, everyone would immediately say that's a crazy system because it gives them an incentive to, I mean, they would say, no, that's not acceptable. And so, I mean, if you put people on salaries, then you take away the financial incentive. Other incentives, I mean, people are human.
Mm-hmm, mm-hmm. Yeah, there may be other incentives that I think come out of salaries. It is true, I think, that the fee for service and Medicare is experimenting with a variety of other sort of options for thinking about how to structure reimbursement, value-based care, right? Looking at outcomes. The problem, of course, with end of life is that you're talking about people who are either likely to die or going to die, and so like what does value look like there? Like what does the best outcome look like if this person's going to die anyway? Well, then it's very preference sensitive. And so this is one of the themes that come up in the book, is that both birth and death are very preference sensitive. The medical outcomes are highly determined by the person's preferences. So it's different than a kidney transplant. Like my preferences of my kidney transplant don't matter that much for the outcome, but birth it does and death it does.
There's a comment in the chat from Jennifer Fadgeman. Dr. Coch is a wonderful end of care physician, and it would be good for him to share some of his thoughts about such things as medication and working with patients and family during end of care.
To share my thoughts about, I'm sorry.
Well, I mean, I think perhaps Jennifer is looking, I wonder perhaps if you had a sort of a narrative, a case that would illustrate some of the difficult issues or something like that.
Well, one thing comes to mind. It's not particularly related to a case, but for most of my career, I've been, and it's been easier as I got near the end of my career and more comfortable in my skin to treat people appropriately with medications at the end of life. And about a year ago, I got a letter from Medicare saying, do you know that you're in the 99th plus percentile of narcotic prescription writers compared to your peers? And I just wrote them back and said, well, really, that's all I'm doing now, and that was the end of it. But probably one of the biggest pitfalls that I see in end of life care, and it should be really simple, is people just do not. They still are hamstrung by worrying about how much medicine they're giving people to make them comfortable. They can't break that mindset from the past. Using narcotics in people post-operatively or with a broken bone is totally different from using it at the end of life, and so they use with very small doses. Incrementally, and to give appropriate end-of-life care, you have to sometimes have a lot of courage to give as much as you need, as often as you need, and also to give families, since they're the ones often giving it, to give them the license to do as you would. My rule of thumb has been, if that dose doesn't work, double it. And of course, people are afraid of killing somebody, but it's hard to kill somebody that's dying. And honestly, I don't think I've seen anybody die of a narcotic overdose in end-of-life situations.
Generally speaking, Bill, do you find that families are, do families pose a problem from the point of view of a physician, or are generally families a really valuable resource?
They're always a valuable resource, but occasionally they do pose a problem. And as I think of the Comfort House experience, we've done, close to 250 patients over 7 years. And I can say, a couple of people lived longer than we thought they would, and they graduated, they went back home, but just with a little TLC that they got at the Comfort House. But the one case, that I still regret that we did not do a good job on, a family member was totally resistant to us giving enough medicines, and consequently that person died in a good deal of pain, and I think we all felt badly about that. And Lauren pointed out that there are often conflicts within families. Not everybody's on the same page about their parent being at the end of life, and more often than not, it's not the one who sees them all the time. It's the one who doesn't see them frequently, who from out of town, that wants to keep going with another round of chemotherapy or doesn't want to give enough medicines.
Okay.
Can I make another comment or two? I think a lot has to do with expectations and adjusting expectations, choosing goals, and educating people or informing them, I think is a better word, of what the options are and what the consequences are. If you take a certain course with someone, what are the complications that may occur? In my field, a patient with end-stage liver disease could die with what's called hepatic encephalopathy, in which they become very demented and then just kind of disappear. Or they can have a GI bleed, which is kind of a catastrophic thing. And it's kosher, I think, to allow that to happen if you inform people of what to expect under those circumstances and how to try to respond and what their resources are going to be. But again, that's very, very time consuming.
We're coming to the end. Let me throw out one very quick last question before, and then we'll wrap up. To both Lauren and Bill, this talk was called The Politics of Healthcare. What would you, if you could sort of identify one or two political measures that you would most like to see happen that would best improve our system, what would you choose?
Well, I'll try to be quick. I mean, this is a really hard one. I think an easy fix, this isn't necessarily going to be a sort of primary fix, but a relatively straightforward fix would be getting rid of certificate of need laws at the state level in the states where they exist, because they prevent sort of competition, and they prevent other providers from coming into the system, and they help create that kind of corporatization that we talked about earlier. Obviously, reforming Medicare is a huge, so going from the most realistic to the least realistic. We have to do something about Medicare. I've been frustrated when I hear calls for sort of Medicare for all, given the current structure of the system. I don't think that expanding Medicare makes sense. I think expanding some kind of universal health insurance makes sense, but what that looks like needs to be very different from the current system that we have. So I don't exactly know how to do that. I mean, I think a system that really privileges and prioritizes preventive and primary care, but that would have to be a system that looks very, very different from the one that we have now. And so I think Medicare reform is really where the reform has to happen. But in terms of what that's going to look like, given the political culture of the US and the strength of physician and hospital associations, I don't have a lot of optimism that the real kind of reform that is needed is going to happen. I'd love to hear Bill's thoughts.
Yeah, if I were going to do something to improve end-of-life care, two things that I would do is One is I would strengthen primary care, because I think palliative care physicians shouldn't be doing this. It should be a primary care physician that knows the patient, knows the family. I know that's an ideal world, and maybe it's long gone. I would do that. And I would also fund research that helps us better predict and communicate to patients. You know, you're not going to live 6 months, most likely. So that people can make better decisions. I think there's a huge gulf between what patients think is going to happen to them and what does happen to them. And I think if we were better we could better communicate. You know, if we think they're not going to live 6 months, I think we ought to tell them, and we ought to have better tools to be able to make sure we're right.
If I can add really quickly to that, there's a couple of really wonderful books. Jessica Zitter has a book called Extreme Measures. There's a book called The Conversation. Atul Gawande has obviously a nice book on death, but both Zitter's book and the book The Conversation, and the author is now escaping me, both of them have appendices that are actually workbooks for end of life decision making. And the best gift that anyone in this audience can give their family and themselves is to think about what their preferences are. And some of these things you can't know if you don't know if you're going to get cancer versus heart disease, right? Like there's a lot of unknowns, and you want to communicate with your doctor, but having a rough idea of what kind of life you would be comfortable with, and communicating your end of life sort of preferences broadly to family as much as possible really helps reduce those conflicts that can prevent physicians from giving you the kind of care that you need at the end of life. So those are some wonderful resources for sort of the average person, since we probably aren't going to reform Medicare after this phone call.
And plus, of course, your book.
Yes, that's also.
Well, I want to thank Bill and Lauren for getting the new season of the Bourbon Forum off to a wonderful, provocative, stimulating start. And that was great. And I hope to see you all next week.
Thanks very much.
Thank you, everyone.